wasn't able to hear anything, so great. I'm glad I'm on.
Well, welcome.
Thanks.
So we're going to go ahead and get started. People are kind of filtering in still, but I want to thank everyone for joining us this morning for Oral Health Day 2020. This is our 5th annual advocacy event, so stacking them up, and that's exciting. It's nice to see so many familiar names, not phone numbers necessarily, but names, as well as new folks joining us. Just so people are aware, we will be admitting, we enabled a waiting room because it appears we had maybe a Zoom bomber. I think that's what they're calling them. So you'll see people filter in more slowly, perhaps. Brady, our communications associate, will be handling that to admit folks in. So I want to go ahead and get us started here. I hope everyone can see my screen.
Yes.
All right, so just as a reminder, I'm sure that all of you are probably zoomed out at this point, but please make sure your audio is muted. We do have it to auto mute everyone when they enter into the Zoom. So if you do need to say anything, you can submit questions via the chat box. Both Kelsey Rostu and Brady, NCOHC staff, are going to be monitoring that. We're also live streaming the event over on Facebook. And so Brady's going to be monitoring the Facebook page to field any questions as well. We have a great lineup of speakers, which I'm really excited about and want to thank them in advance, for sharing their expertise and experiences with us today. And if you have questions specific for content related to the speakers, you can go ahead and put that in the chat as well. If speakers have time after the presentation, they can answer and field those questions directly. If not, we'll take and answer all of those at the end during the Q&A. So a little bit about who we are. Most of you probably know us by now. There are some new names, like I said, that I don't recognize. So I'm not sure if you are familiar with the Oral Health Collaborative, but we are a program of the Foundation for Health Leadership and Innovation. Here is our great team. I just want to thank them as well publicly for all the work that they put into this event. I think it's going to be a great event. And I just wanted to give you a chance to see them in the virtual world. Obviously, we're not able to connect face-to-face at this time, but Kelsey obviously is in the middle and Brady is on the right side. Both come highly skilled, and we're very lucky to have them on board with us at the Oral Health Collaborative. So our mission more broadly is to improve the overall health and well-being of all North Carolinians. And we do that by increasing access and equity to oral health care delivery through collaborative partnerships, advocacy, and education. More specifically, we have 3 pillars of focus. And so I mentioned 2 already. So that's community partnership, collaborative partnership, and advocacy. But we also provide resources for providers, our partners more broadly, the community, policymakers, etc. So if you haven't already, you can follow us over at oralhealthnc.org, and then you can see all the resources that we have listed on our site. So a little bit about Oral Health Day. Those that joined the pre-event webinar have already seen this slide, but I want to make sure that those that have not had a chance to meet with us for Oral Health Day yet understand what the event is about. It started in 2015. So like I said, this is our 5th year. We're really excited. This photo that you see was taken from last year's event during our debrief session. So typically, we are not virtual with these events. So this is very new for us. So if you can make sure that everyone is muted, please. Perfect. So typically, we host this right outside the General Assembly, and it's a day filled with speakers. And then we break and folks meet with their representatives to discuss pressing oral health issues for their community. And then we form a debrief session just to kind of chat about what those visits entailed and next steps forward. So this year, like obviously we're virtual and it's pretty fitting, I think, that we're doing this virtually since the theme of this year is teledentistry. So we'll see how technology works or doesn't work. Definitely provide some grace because we will be inevitably probably encountering some hiccups today for our technology. So why teledentistry? So I'm going to give a little bit of a frame before we dive into the speakers. So kind of a snapshot that many are familiar with that work in the oral health space, but those of you that don't may not be familiar. North Carolina definitely has some concerns and some barriers to addressing its access disparities. And so our state ranks 37th in the country for dentists per capita, meaning there are 49 dentists per 100,000 people in the state. We have 3 counties in North Carolina without a practicing brick and mortar site employing a dentist. And then 1/5 of all 100 counties hold the most practicing dentists. And then kind of drilling down a little bit further with that, there are 74 out of our 100 counties that are designated as dental health provider shortage areas deemed by HRSA. 76% of North Carolina dentists are in private practice, and only 30.7% and those in North Carolina practicing dentistry participate in Medicaid. So as you can see with these statistics, our rural communities, those vulnerable communities and populations definitely have barriers to access. So I mentioned 74 of the 100 counties in North Carolina are considered dental health provider shortage areas, and this is just a map that shows that. So the green counties are those that are deemed to be in shortage of dentists. And then those in gray are not. I had mentioned 1/5 of 100 counties hold the most practicing dentists. Rural areas, as you can see from the map, are especially underserved. I like this map because it does show kind of the corridors, the I-95, the I-77, I-40. So you can kind of get a sense as we migrate away from the highways into more rural communities, there are less practicing dentists. So the lighter green that you see on the map means less dentists. The darker green means more. So as we think about teledentistry as a way to address access gaps and really to address the urban-rural divide that we have in this state and this country, it's really telling to look at that 40% of all North Carolinians live in an area designated as rural. So that's over 4 million people. So I'm going to just touch on a little bit, just broadly, the benefits of teledentistry, and then you're going to hear firsthand from our speakers how teledentistry has helped in their clinical practice in reaching the underserved. So teledentistry broadly will help reach underserved populations. It addresses socioeconomic disparities, improves specialty care and consultation, decreased costs in terms of travel, and improves the oral systemic integration. So you will often hear people describe teledentistry as the triple aim. So those that are in healthcare administration probably hear the words triple aim in their sleep. But really what that means is we're looking for modalities that will improve health outcomes and reduce cost and improve the patient experience. So here is the lineup today for our speakers. I will not be introducing each individual speaker before they speak due to time, but I did want to make sure that you had a good grasp of who they are. So the slide that is in front of you is in order of the speakers. And so we're going to kick it off with Darlene Laseth, who is the Executive Director for the Cornerstone CDC. And then we're going to move on to Representative John Autry, who represents District 100 Mecklenburg. and then on to Dr. Sean Matthews over at UNC Adams School of Dentistry, and then to Dr. Flores at ECU School of Dental Medicine, then Dr. Bill Donegan over at Contegra Health, then Dr. Alec Parker, the Executive Director at the North Carolina Dental Society. Then we're going to round it out with Bobby White, the CEO of the Board of Dental Examiners. And then lastly, with Representative David Lewis, who is representing District 53 Harnett. So I'm going to go ahead and stop sharing my screen now, and then we're going to start with Darlene.
Good morning.
Good morning.
And welcome to Oral Health Day 2020. This is a great and wonderful day that we are here today to celebrate 5 years of Oral Health Day for the state of North Carolina, as we come together to collaborate and to find the resources and to make sure that we're making progress. And as I say it, and I can say it again, and I'm not there before you, because if I was there before you, I would be moving around, and as we are about zoomed out, but you know what, I'm zoomed in because this day really matters. Oral health matters. My engagement has started over 15 years ago, where I had an opportunity to sit at the table along with the Center of Disease Control and individuals and talk about a special interest project in regards to oral health. How could we improve the access in rural communities? So by way of Zoom today, I am here to tell you today that, again, it matters. And to you, Dr. Brian, we want to give a high praise, and we want to say thank you for coming in and pulling us together and bridging the gaps. And when we say teledentistry, we're moving forward, because even at the cornerstone, we're moving forward with technology to make sure that our folks can, and individuals that we work with, can have accessibility to oral health, because it really matters this day. Moving it back and talking a little bit about my personal background from the days of being a social worker, for the days that I was able to engage and work with folks, and to know that it really matters with that smile and making sure that over 40 years ago, when things were just that, from the military, for the veterans that we represent and we working together with, is that oral health mattered. That smile, it really mattered. And it, again, we have gotten to the point that today on this 2020, it was one of the goals of Dental Quest Foundation that I bring my synergy, because they were the first one that gave us the funding to do Oral Health Collaborative right here in the wonderful town and county of Duplin County, which I represent on behalf of Representative Jimmy Dixon and Senator Brent Jackson this morning. If you're listening, if you're looking, it was right here in Duplin County that we were able to start to bridge those gaps, to making sure that everyone had accessibility. It's beyond this toothbrush. Yeah, I got to show it to you. You know, it's beyond the floss, and you know, it's beyond the toothpaste this morning. Yeah, but it is about having those vegetables, and it is about the community engagement that we had in regards to North Carolina UNC coming to our communities to bring about hope work projects 10 years ago, where we were able to start to build capacity with a community garden. Because again, when you think about, and when you know on this day that our kids and the poverty that does exist, but again, if they're going to eat sugary cereal, you know, again, they're going to have some sugary results in their academics and the things that we have brought together down through the years. Let me take it slow and let me say it slow. Oral health matters. This day matters. This day is very important. It matters because, again, as I have said down through the years, and I think I did even say it at one of those meetings that I was in, that I represented. Yes, my makeup is important, but it is my teeth where it all begins. It's my mouth. It is knowing that this makeup I may have on, but it's a beginning thought that when you start to take care of the mouth matters, because it will all affect other parts of our bodies. So again, we have been engaging our communities to make sure that, you know, the basic necessities is beyond the flossing, it's beyond the brushing of your teeth, because those are the things that we learned from our parents on what to do and how to do it. But again, getting and making sure that we have the resources that are available to help improve oral health outcomes. And today I am just so proud and I'm just so honored for this opportunity as I think about where we've come from. And I wouldn't take nothing from my journey. I hope there's someone out there today that can feel what I'm saying to you when we think about oral health. As I stated, the veterans, you know, that had just stand in line and have been there, and to know that veterans do not have accessibility to oral health care in 2020. It breaks my heart on today, because our veterans matter. They have protected us and they have made a difference. And that is what I'm saying to you. It really matters for our senior citizens that have worked in systems and school systems and have built capacity. And this is the African American community that I'm talking about. There are seniors at 70 years, 80, 90 years old that they no longer have dentures and they cannot get care. There is a problem, there is a situation, and it's personal people that we are working with to make sure that those seniors are able to get access to having dentures. I don't want to start crying, but oftentimes they tell me I'm crying when I'm talking, because it's in my heart, it's in my soul on this day that oral health matters. And it matters for the Latino population. It matters that they have access. We did a focus group a couple of years ago, and the individuals, Latinos, were invited to our focus group, and they just came in crying because they oftentimes go to bed with a toothache, not knowing that they can go to one of our local providers to get oral health care. So it matters. It matters so very much. And on behalf of what it is that I do today, in working with apartments and working with low-income apartments and working with individuals that just don't have the access, and working with folks that live in trailer homes that's full of mold and full of all kind of other conditions. We today on this Oral Health Day, it matters. You matter, and we all matter. And Dr. Brian, you're smiling, but I'm happy on the inside, because when I think about where we've come from, and on this day, it is Oral Health 2020 that we're bridging the gaps. And those folks that continue to come into the cornerstone and around and about, we're social distancing, but there's still individuals that are having problems, that have no teeth, that have no dentures, that need help, that need resources right away, immediately, right now. So this plea today, and I thank you this morning, and I'm gonna calm down, you know what I mean? Because my energy is flowing. It's flowing, because when we can all join hands together, and that's what Oral Health has taught me on behalf of the North Carolina Oral Health Collaborative, over 15 years of engagement with North Carolina Oral Health Collaborative. It matters that my niece, who is a dental hygienist, is leading and is a leader in her community, where she's working tirelessly as a dental hygienist, but making impact. It matters in our local community. Dr. Theodore Thomas, who has been a dentist for many years, but want to give up and retire and enjoy some of the days. But if he leave, who can take his practice? Is serious. It's a serious matter this day. But I do know that we do have some solutions. On behalf of the DAB, Chapter 90, we thank you. 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 Chapter 94. We thank you for what you're doing and working with veterans and working with individuals. Because when Brady came to us and he came into the meeting, we were just so engaged to know, and we're very thankful that we have oral health resources. We have information that we can share with veterans, seniors, Latinos, those that live in apartment complexes, those that live in trailer parks where there's low access to health. The disparities are rising. I don't even want to go on the COVID-19. I'm not going to go there because you know what? This is how I.
Darlene, I think you're muted.
I'm sorry. I'm getting ready to wrap it on up and bring it on home. I don't know how that happened, but I was actually showing the funny face because this is how we look these days.
Well, I can say, on behalf of the collaborative, we definitely appreciate your enthusiasm, your passion to increase access for those vulnerable communities. And I think we heard that coming loud and clear this morning. And I want to thank you for being willing to speak, and get us started for Oral Health Day.
I want to give you one more thought,
Yes.
because as we are forging together and making sure that folks have accessibility, we are honored and we're thankful for AirProbe USA that is providing education in regards to technology and drone technology right here in Duplin County. So I want to give a shout out to AirProbe UAV along with UNC Hippy Dippy program and regarding day one disaster as we move forward and we make a difference. Thank you all so much and have a wonderful day. And thank you for this opportunity.
Well, thank you again. I think we can speak. I'm reading the chat. So many positive, comments coming in about your discussion this morning, and really focusing Oral Health Day on, those that lack access and highlighting those disparities. So Darlene, thank you again.
Thank you. Have a great day. Thank you.
Absolutely. I think we will now, at listening so much energy. You have me hyped, right? You have me injected with energy. So thank you. We're going to move on to Representative Autry.
Good morning.
Good morning.
Well, I don't know how to follow that. I mean, it's like the old showbiz adage, you never work with children or animals because they're always going to upstage you. I'm glad to have Melissa upstage me in this effort because that kind of energy and enthusiasm is infectious and it is necessary because that kind of energy can motivate people to action. I want to thank everybody for being with us this morning. Thanks, Dr. Bryan, for the invitation and Brady for helping me navigate and through because I have a committee meeting to get to this morning. So I appreciate everyone allowing the flexibility in today's schedule. I am a native North Carolinian, a Tar Heel born and bred. I grew up in Cumberland County. And in my youth, a trip to the doctor's office was rare enough that the trip to the dental office wasn't even a consideration. I grew up I was born in 1953, so everybody in my family dealt with their teeth with whatever condition they were in until they were in their 20s. And then there was that ubiquitous trip down to Florence, South Carolina for a one-day full extraction and immediate denture. And that was the way everybody expected the way their life was going to roll out. But then I joined the Navy. And in the Navy, I became a dental assistant and worked chairside. I was a scrub tech in the operating room for oral surgery at the Naval Hospital in Portsmouth. I went to Camp Pendleton in California and worked on marine teeth. And to ensure their readiness, I took x-rays, I sat chairside, I worked in endodontics, doing root canals, and really found a path for me in preventative care, instructing Marines in preventative care. And I remember one day in a class, whenever a couple of wise guys in the class were mouthing off about the whole process of flossing and so forth. And there just happened to be a staff sergeant in the class also. And he made a point that, what you don't want to do is to end up being in the field in an intense situation and have a toothache. And so the readiness of the troops was at the forefront of the way that the Navy took care of its sailors and its Marines in their health care. But I saw a lot of interesting stuff in the Navy. I thought I had been deprived of proper dental health care, but I remember seeing folks from all over the country. And one of the first visits they had was with me for preventative care, but also that initial gross scaling. And I don't know how many people remember what a Cavitron was, but I have used Cavitrons to remove blanket calculus on posterior teeth on new recruits into the Marine Corps. So the importance of dental health and the necessity for it has to be a part of a holistic approach to healthcare. Because if you don't have good teeth, how do you chew good foods? How are you going to be able to deal with good solid vegetables like apples and green vegetables and fruits? So the holistic approach for good health care has to also include dentistry. And I think that telehealth is going to be a revolution that we're in the midst of. Especially at the approach of when it comes to dentistry. Now, in my first initial thought about telehealth and dentistry, well, what can you do? You can't take an X-ray. You can't get in there with an Explorer and a mirror. But I think the opportunities for preventative care should be put to the forefront of this, because you can certainly instruct someone on how to floss and brush and take care of their teeth, and hopefully, prevent those the compounding of the issues of what caries can do and what not being able to take good care of your own teeth for yourself, and how the supportive tissue of your gums and the bone structure underneath have to be there to have good dentistry, a good dental health. So oral health care certainly at the forefront, and something that I can remember with my children when they were small enough that they would get down on their knees on the floor and put their head back on my leg, and I would floss the teeth for them until they were about 5 or 6 years old and they could handle a floss threader on their own. But as you keep moving forward here, find those opportunities. And one of the things that's going to be imperative to be able to deploy a good telehealth system that includes dentistry is that we have broadband access throughout the state of North Carolina. And so that has to be the infrastructure that what you want to do is built on. And that's going to take some action from folks in Raleigh to make sure that the mechanisms and the institutions are set up to provide that backbone and that infrastructure so that you can do the work of the people and help them to understand how important oral health is for them. So I appreciate this opportunity this morning. Thank you so much for your time. Thank you for letting me share a little bit of my story. I'm going to slip off now and finish preparing for the Appropriations Committee meeting this morning. But please, I want you to think of me as a resource in the legislature. I am someone who absolutely understands the impact that good oral health can have on our society. And I want to be an instrument just, in that top drawer in your operatory that you can pull out and call on and rely on and use me as you see fit. So thank you all very much. Have a great day. Have a great conference. And I hope to see you again very soon. Thank you.
Thank you very much. Thank you for being a champion and understanding how oral health impacts the whole person. So thank you for that.
All right. Thank you.
Take care. So now we're going to move on to Dr. Sean Matthews over at UNC Adams School of Dentistry, and he will be sharing his screen, so you should be able to see his slides soon.
Thank you very much, Zach. Can you hear me clearly?
We can hear you
Good.
loud and clear.
Good. First of all, hello to all of you out there. My only regret is that we are not able to do this in real time, face to face, but these are challenging times. I'd like to first of all thank Zach and the collaborative for the kind invitation to speak to you today over the next 20 minutes as part of this wonderful Oral Health Day. And what an incredibly enthusiastic start we've got off to, which will be a hard act to follow for sure, but I shall do my best over the next 20 minutes. My journey and my interest in telehealth in general started in my previous life in the United Kingdom. I was recruited here to the UNC Adams School of Dentistry 5.5 years ago, and I'd already dipped my toe into the telehealth water back in London. And I came here and was fortunate enough to have been embraced by Dean Weintraub, who recruited me, and our current Dean De Rossi, who continued to wave the banner and saw the importance of teledentistry to our school and also to our state. So in that role, I was provided with the role of Director of Teledentistry here at our school. So it's on that basis that today I will talk to you about teledentistry's approach in practice, the synchronous consultation. So what I propose to do is, first of all, talk to you about the what, and just quickly define what teledentistry is for those of you who may not understand it entirely or know about it entirely. And also the how. And the best way of really demonstrating that is by showing you a simulation video of a teleconsultation of mine with a patient who lives way out west, past Asheville in North Carolina, which I think will be quite impactful. At least I hope you think so. And also the why. Why is it that we're here today? And I think this will be highlighted by some of the oral health statistics that Zach's already eloquently articulated at the start of the talk today. And finally, the when. When should we be considering pushing the barriers further for the implementation of teledentistry here in our precious state of North Carolina? So the what, the how, the why, and the when. So first of all, what? This is probably one of the best definitions that are inclusive of teledentistry that I've come across. It's essentially the delivery of oral health care to include consultation, diagnosis, treatment, and importantly, education of patients and providers using interactive audiovisual communication techniques. It usually involves two places of lesser and greater medical capability that are geographically separated, often by vast distances, and you can connect those two places by using telecommunications. You have to have three parties ideally in a synchronous teleconsultation, which is what I'll focus on for most of my talk to really make this work. You have the beneficiary, that's the patient, and that patient is referred by their provider, the referring provider, for specialist services to a consulting provider who is remotely located some distance elsewhere. So here we have an example of a patient with their provider, their referring provider at the originating site. Patients can either constitute new patients or follow-up patients. You can cover the span of what's on offer essentially. And at the other side, the distant side, you have the consulting provider linked by whatever kind of telecommunications modality you choose to use. We all are all too familiar now with the role of Zoom. There are many others out there that provide a similar function, but this is the world in which we now currently live. The requirements to effect a teleconsultation of the synchronous kind are actually minimal. And these are things that we have all learned to embrace for hell or high water over the last 2.5, 3 months since COVID-19 reared its head. It's already been touched on the importance of a good broadband connection. That's especially relevant when we are talking about people who live in the rural and underserved communities where broadband connectivity can be an issue. You've got to have a Windows PC or an Apple Mac, whatever your chosen PC device is. But the all important thing is that you must utilize HIPAA compliant software, especially when you're talking about the transference of patient information, patient data. The rest of the things on this list are things that we all invariably have already. Web cameras, microphones, speakers. This is the kind of thing that we are all used to using now as part and parcel of our virtual lives. Teleconsultations can also be effected on our smartphones or tablets, iPads, and so on. Now, 4 types of teleconsultations are described. 4. The one that I will focus on is the synchronous real-time live video consultation. The other 3 are annotated here. There's asynchronous, or affectionately called store and forward, the remote patient monitoring, and the best example of that is probably tele-ICU, tele-intensive care, and finally, mobile health, where you're using a mobile device to effect a teleconsultation. But I will focus on the first of these for the purposes of this talk. So the synchronous consultation is a real-time being the key phrase here, live two-way interaction between the patient and their referring provider and a consulting provider remotely placed miles elsewhere using audio and visual technology, Now, the best way, I think, of demonstrating how it works. So we've done the first part of the process. We're now going to talk about the how. How does it work? A synchronous teleconsultation is probably best demonstrated, I think, in this simulation video, which I will now show you. This is actually a patient of mine who lives, as I said, way out west, past Asheville, North Carolina. And it lasts about 6 minutes. I'll remain silent while hopefully you can hear it and follow the process. Well, first of all, hi, Megan. It's great to see you again.
Hi, it's good to see you.
Thank you. And you were last here at UNC School of Dentistry, what, 2 weeks ago?
Yes, sir.
And just to confirm, you had both of your jaw joints replaced by me about 2.5 months ago, by my reckoning.
Yes, sir.
And where do you live?
I live in Morganton, North Carolina, so it's about 3 hours away from you.
3 hours away from you, great. First things first, let's have a look and see how the actual wounds are healing, if you don't mind. So we've got a wound in front of your ear and one underneath your lower jaw, which is what I use to access the implants and to put them in. Would you mind just showing me the one on the right-hand side first of all?
My right hand?
Yeah, that's fine. Just pull your hand back. Okay. So that looks great. I can see the preauricular wound quite nicely, the one in front of your ear and the one on your jawline. Again, that looks fine. That looks nicely united now. Have you started to massage those scars at all yet?
Yes, sir.
Okay, because there's still immature scars. What about the one on the left-hand side, please? Yeah, good. Again, that looks fine. You've got a nice, yeah, that looks, you're a good healer, actually. Well done. I was going to change the image now into a slightly different view. Can you see me?
Yes, sir.
So what I want you to do is I want you to start massaging the scars with a bit of cocoa butter. Just apply it along the length of the incision sites, both in front of your ear and underneath your lower jawline. That's the cocoa butter. And gently massage the cocoa butter in using a very light circular motion until all the cream has gone. And it's not so much the cream that's important, it's the massaging effect that's important. It'll transform that scar into an immature scar to a mature scar. Now, the last time I saw you, kind of 2 weeks ago, one of the main concerns about this kind of an operation is the effect it has on the nerve, the facial nerve that moves the muscles of your face. Yes, again, it can be a risk, as you know, we spoke about that at length. And things are progressing well. We had a little bit of sluggishness affecting some of the nerves, I think, predominantly on the right-hand side. Can we see how that's actually improving now, as the case may be? So let's start with the one at the top. Can you raise your eyebrows for me? In fact, that's the left-hand side I was referring to, not the right, the left-hand side, correct. So raise your eyebrows, good. So it's improving. The left is still lagging behind slightly, but it's getting a lot better. Can you frown for me? Give me a big, deep frown. Say, I can't stand that Dr. Matthews. He's terrible. Very good. So frown again. Much better. Do you see an improvement?
Oh, it's a ton different. Thank goodness.
Good, excellent. I knew it would be, no problem. Second thing, can you actually screw your eyes up as tight as you can for me? Really tight. That was fairly symmetrical. Good. Relax. Can you puff your cheeks out for me now? Again, that looks very symmetrical. That's also a lot better. Great, well done. And now show me your teeth. Give me a big smile. Excellent. Tiny, tiny little bit of weakness interestingly, on the other side, on the right-hand side, actually, not the left-hand side, but again, much better, so that's improving.
Okay.
I would also like to share this, just to see whether or not you can see this. In fact, this is part of the exercise of information sharing.
Okay.
Can you see my computer screen?
Yes, sir. I see. It looks like it's scanned.
That's a scan. That's your scan, actually. This is a scan of you, your jaw joints. And what it shows is the severity of the problem here as far as your joints are concerned. It's sometimes easy to forget where you came from. So over here, if you can see my mouse,
Yes,
this is your right jaw joint. That's a jaw joint of someone who's not young and healthy as you are. It's jaw joints of someone who's in their 70s or 80s, significantly degenerate and significantly arthritic. And if I scroll through on the other side here, you can see similarly the problem with the jaw joints you have on the left side with a significant amount of bone around the joint, which was the reason why you could not open your mouth. You had severe limitation in mouth opening because of all this extra bone that had grown around your jaw joints. Just as a matter of interest, and also for colleagues who are listening to this type of teleconsultation, it's always interesting, I feel, to hear the view of the people who matter most, that is you as the patient. You've not been involved in this kind of teleconsultation before. You're an educated lady and an educator as well, clearly. What is your view? Do you think this kind of consultation has merit from the patient's perspective, and if so, how?
absolutely. So this is the second day of school for me, and I teach kids with moderate to severe disabilities. So me being here is imperative, and driving 6 hours, I would have had to take off the entire day to come see you, and that just wasn't really I mean, it would have been an option, but I would rather that not be an option. So being able to do this on my lunch break makes all the difference in the world. You got to see my scars and you answered my questions, so I would do this more often.
Excellent, good. So you would support it and encourage it, and as being a very worthwhile thing to progress with and proceed with.
Absolutely, yes, sir.
Do you see any limitations from the patient's perspective? For every positive, there's always maybe a negative, things that we haven't thought of as clinicians at this end that we can do better. Do you see any drawbacks at all?
No, sir. I mean, you sent me the email. It was very easy to access. And you answered all of my questions. So no, sir. I think I'm good.
So the technology part of it, that's also the key component. That's why it's called teleconsultation. From your perspective, no problem.
No problem at all. It took not even a minute to pull up on my screen. So.
And what's required of your end as a patient? You just have a simple laptop computer and a camera, nothing else.
Yes. And then I just downloaded the Zoom.
Yes.
It linked, it downloaded, and we were good to go.
Good, fantastic, excellent. Good. Well, I hope you can see from that teleconsultation the benefits of this kind of technology in the synchronous world of teledentistry. I think that's a relatively good example of it. So we have spoken about the what is teledentistry. We've spoken about the how it works, just demonstrated. And now why are we here? Why is it important? It's important because it matters. That's why it's important. And I think Darlene articulated that beautifully in her opening remarks. It matters to all of us. So it should matter to all of us, actually. Patient, provider, advocates, whoever we are, it's important, it matters. Zach's already mentioned in some of his earlier opening slides, so I won't labor the point, that we have tremendous oral health disparities here in North Carolina. And something like 40% of our population live in the rural areas and have limited access to oral health care. So that's 4 million people. That's a lot. And there are many barriers that exist to oral health in rural North Carolina. So patients in the rural community will have often have higher rates of chronic disease. They often have higher rates of underemployment, unemployment, and poverty. They have a higher percentage of the aging community live in the rural environment, live in the rural community. There are far greater dependence on public insurance coverage like Medicaid. Patients who live in the rural community have lower rates of dental insurance. Public transportation and even reliable private transportation can be a challenge for them to get to their appointments. So all these points listed on this slide represent clear barriers to effective oral health for those who live in the rural community of North Carolina. This booklet, produced by the Oral Health Collaborative a few years ago, I believe it's in the process of being updated, and Zach could correct me if I'm wrong, is a great read, actually. And the statistics that it bears, that it carries, I think are worthwhile just hammering home just briefly. And the important ones are listed here, and this relates specifically to North Carolina. As the first bullet point intimates, something like 88 per 10,000 of the population in our state attend emergency departments for dentally related visits, like toothache related problems. That's more than twice the national rate and the fastest growing relative to other states in the southeastern parts of the US. That's not a statistic to be proud of. 13% of our kindergarten children have untreated tooth decay. At the other end of the age spectrum, something like 1 in 5 of North Carolinians over the age of 65 have no teeth at all, 0. When we look at the children and we break them down by ethnicity, you can see here that something along the lines of 55% of American Indian, 52% of Hispanic children, and 30% of Caucasian children have untreated tooth decay. As Zach's already mentioned, the vast majority of dentists are concentrated in urban areas in a fifth of our counties, and 3 have no dentists at all. And when we look at the national rate or pickup rate of dentists who accept Medicaid patients in the community here in North Carolina, we are well below the 42% national average, actually. I believe this is now at the 30%, but we're still well below the 42% national average. We now rank 37th nationally in dentist to population ratio. And again, Zach's already, I think, glossed over this slide, so I won't labor the point here. And 74 of our 100 counties are classified as dentist health professional shortage areas. So these are not statistics that we should be proud of. We need to do and can do better. And I think this kind of an event like Oral Health Day, where we are garnering the forces, creating advocates, and selling our message are critical to making sure that we do better. As I mentioned earlier, in terms of emergency department dental visits in North Carolina, we are not doing terribly well. They attend at twice the national rate, as shown by the graph here on the left. So North Carolina is climbing and has climbed between 2007 and 2013. And the other states adjacent to ours are at a much lower level. And when you consider that in 2012, we here in the US spent something like $1.6 billion in dental visits, ED, emergency department dental visits alone, it costs you and me as taxpayers approximately $750 per visit. So every time a patient turns up to the ED with a dentally related problem, that's what it's costing us as taxpayers. And really, these patients should have no reason to get as far as the ED department. When you're challenged to live in the rural and underserved communities, you can't afford to go to a dentist, or there's no dentist to access, the emergency department is your first port of call. This again hammers home the point that we here in North Carolina are well below the 42% average rate of dentists who accept Medicaid. The main reason for this is that reimbursement rates for Medicaid dropped dramatically in the 10-year gap between 2003 and 2013, decreased by about 22%. So if you're not going to incentivize dentists to want to accept Medicaid patients by paying them appropriately for consultations, then it's obviously a no-brainer why patients or why dentists will not treat these patients. So we need to look at the reimbursement of Medicaid patients. We need to look at parity of payment, especially when it comes to teleconsultations relative to a normal face-to-face consultation. These are all critical issues that have to be addressed. Now, there is a lot of bright light on the horizon, I'm pleased to say. The American Dental Association is fully on board. In 2015, as far back as 5 years ago, they passed guidelines on teledentistry, which are now all-encompassing. They went a step further 2 years later and actually created 2 billable teledentistry codes that dentists can now be paid for if they effect a teledentistry consultation. The problem is that those codes are still poorly paid, and they're not paid, there's no parity of payment in the context of a true face-to-face consultation. So again, it's about trying to incentivize dentists to want to embrace this technology and offer this to patients in a well-meaning way. Nationally, 42 states currently authorize dental hygienists to provide what's called direct access care, which means that they can actually see patients without the prior supervision or without the supervision of a dentist being attending. So North Carolina is not one of those states. 8 states offer synchronous reimbursement for synchronous teleconsultations. North Carolina is one of those 8 states. 5 states reimburse for asynchronous, the store and forward modality. North Carolina is not one of those states. So we are okay. We could be better off, but we've got a long, long way to go to catch up with our other colleagues nationally. I call this the wheel of misfortune. And when we look at the pie that's carved up here, which defines the 50 states around the perimeter of the pie, North Carolina is down here at the very bottom, if you can see my cursor. This is color-coded to highlight the scope of practice of dental hygienists state by state. We want to see a nice block of color, which relates to what they can actually practice and physically do in practice, as shown here by this list on the right. But if you look at North Carolina, there's a complete whiteout. We are in the exalted company of Mississippi and Delaware. Our hygienists are well-trained, highly trained, frustrated, and rightly so. They can do much more, and they really are, it's important they play a pivotal role in the delivery of teleconsultations statewide. And this is why this also has to be looked at and addressed, what dental hygienists can currently do in terms of scope of practice in North Carolina. So these are the barriers essentially that I think need to be looked at. The issue of reimbursement I've already mentioned. The issue of parity of payment with a real-time face-to-face consultation I've mentioned. The issue of giving dental hygienists this ability to have direct access to patients without having to be supervised by an attending dentist on site. So the final part is the when. When should we be looking to make that final push or this further push to implement teledentistry in our state? Well, I would suggest the when is now. The future is here and now. And it's here now because of this little fella. 2.5 months ago, the world changed for us all. We now live in a virtual world because of the coronavirus. We now live in a world where we all greet each other with masks. We can no longer hold and hug and embrace our friends and colleagues in the way that we did previously. Things have changed. We now have to conduct our contact and our educational component, our conferences through this kind of virtual modality. It's not quite the same in my view, but still, it works. The important changes that have been implemented during the virtual pandemic world for the purposes of teledentistry relate to restrictions that have been relaxed in allowing us to be able to deliver teleconsultations across state borders, which was not the case pre-COVID. The Office of Civil Rights on Capitol Hill, whose job it is to oversee HIPAA compliance in the healthcare provider world, have relaxed and said that they will not impose penalties on dentists who breach HIPAA compliance rules as long as they're seen to be acting in good faith for the benefit of the patient. This is just during the COVID pandemic, which we currently find ourselves in. North Carolina Medicaid, which previously in our state reimbursed only for synchronous consultations, now will also reimburse for the asynchronous consultation as well. These are temporary measures. And although this last bullet point, things are relaxing, previously we were just dealing with urgent and emergent cases during COVID-19. And gradually we drift back to work. Normal services, near normal services are being reinstated, but in a very different way. What we must not do, what we cannot afford to do, is revert back to the old norm. We have to make sure we retain as many of these temporary, in inverted commas, initiatives that have been in place during COVID. It's important they remain in place after COVID. We know that teledentistry works. There's so much out there that dictates that is absolutely the case. We can learn so much from our colleagues in medicine who've used telemedicine for years for their patient care. We need now to embrace it in teledentistry. In order to make North Carolina leaders in dental care, we need to learn from other states like California and Colorado and Washington and others who are a lot further down the line than we are in using teledentistry for the purpose and benefit of their patients. We need to lead through education, and we need to lift those barriers which I touched on earlier by the implementation of good policies. And we have a dental society and a state dental board who are absolutely fully on board with it. And I had the privilege of working with many of them over the last 2.5 years in my role. And there's no question that the right personnel are at the table including with the help of the collaborative, to make this a reality here in our state. Our school, I'm proud to say, has been heavily involved in this movement for teledentistry through the first statewide summit we held in October 2018, which was for stakeholders only, invited guests. Then on March the 6th of this year, 2020, we had another teledentistry symposium held jointly with ECU School of Dental Medicine, which was for all comers, anyone remotely interested to learn about teledentistry in our state. Where are we now and where are we going? Little did we realize that a week after this teledentistry symposium was held, how the world would change. But we literally went down into lockdown mode in our state and throughout the United States. This primed us for what was to come. It was in people's minds and psyche, and there's no question it helped us at our school to be able to deliver this virtual oral healthcare helpline, which we got up and running in 3 days of chaos and incredible hard work to help deliver a virtual service during the pandemic for those throughout our state who had dental emergent problems. And the final thing I would say, just wrapping up, is that one of the other flickers of light on the horizon is the fact that public health dental hygienists in our state now can actually exercise their right and have direct access to treating patients, implementation of treatment plans through the hard work of many of the individuals I've just mentioned, our society, Dental Society, the State Dental Board, the Collaborative, and numerous others. So baby steps, but steps indeed they are, and steps forward. So as an oral and maxillofacial surgeon, this is the kind of thing I see all too often, and I find it very frustrating. Patients who turn up to the emergency department when I'm on call with a face like this, his eyes closed, eyesight's compromised, his face is swollen, all because of a toothache. Patients like this, whose airway is compromised to the point that he has to have a tracheostomy and a breathing tube put in his neck because he's so swollen that his tongue protrudes from his oral cavity, all because of a dental abscess, a tooth-related abscess. It's easy to forget that patients can die from dental abscesses, dental infections. So the delivery of oral health care using teledentistry, synchronous, asynchronous, whatever modality one uses, is critical to keep this kind of a patient out of our ED departments and out of this kind of invasive, life-saving treatment. We can do it. We need advocates, and we need you. So on that basis, I'd like to thank you for your time. And I'd like to say finally, this is actually going to be my last presentation, actually, before I leave North Carolina for fresh new pastures. I can't think of any better way to go out, quite frankly. It's been a pleasure working with many of the people on this conference call here. I'm passionate about this, and we are so lucky to have lots of wonderful people at the helm driving this process forward. And I wish you all well in the future moving forward. Thanks, Zach.
Thank you, Sean. That was wonderful. Just reading some of the comments, I think demonstrations are always very valuable for people to see. I'm glad that you also touched on just the equipment needed, that it's not as robust as what people may think when they think of telemedicine, telecardiology, etc. It's not a big cart we're reeling in, right, to see a patient. And so that's important for folks to understand. We do have one question, and we have a little bit of time. I just wanted to get to that. It's from Elaine over at Delta Dental. And she says, regarding expansion of scope of practice for hygienists, are you referring to the provision of care in rural areas with certification, or has something more been done?
I'm referring to both the expansion of care with regards to certification, but also giving hygienists, as we have done with the public health hygienists here in our state, hygienists who work in dental practices up and down the length and breadth of our state, the opportunity to work to the full scope of practice. I mean, as I said, we have an extremely well-trained group of hygienists here that come out of our school year upon year. And you and I both know that because we were invited to speak, to present at their conference in Winston-Salem in October of last year. And I personally found the energy in the room amongst the hygienists who were just so embracing of this technology and were desperately willing us to help them do more and get more involved in this kind of work was cathartic. What I didn't mention is that, you know, here in North Carolina, there's proposed to be a shortage of dentists over the next 5 years. The number of dentists in our state will be diminishing. The number of hygienists in our state will be increasing. So we need to look at workforce reallocation to ensure that if we've got personnel who are trained to do initial screenings, why are we not using them? Why are we not allowing them to be able to have access to screen these patients and deliver care, especially to those in the rural and underserved communities? So that's an important piece, I think, that really does need to be thought out more closely.
Thank you so much. I'm just answering a last question here, and then we're going to move on.
Was there another question? Sorry, Zach, did you say?
Yeah, so Elaine was just confirming, thank you. So no new legislation has been passed to enable them to practice at full scope. So I was just giving kind of a clarification.
Correct.
Within public health, dental hygienist, there is more direct access based on the new rule that we co-sponsored with the North Carolina Dental Society that went into law on February 1st of this year. So if folks want to Google that or research it, or if you have questions after, feel free to reach out. Sean, I want to say thank you so much. We've known each other about 1.5 years now, and you're going to be desperately missed in this state, but I have no doubt that we'll keep in contact, and you'll keep in contact with the other folks in this state to help us see it forward, to accomplish this goal that we've all set out at various stakeholders to do around teledentistry.
Absolutely, no question about it. Thanks, Zach, a privilege.
Absolutely.
Take care.
So now we're going to move on to Dr. Flores over at ECU School of Dental Medicine.
Okay. Hello. Good morning. Thank you so much for having me. I'm appreciative of the opportunity. Teledentistry is usually something I'm deeply involved here at ECU, so I'm always excited to talk about it. So I will be focusing mostly on asynchronous teledentistry, and then I'll talk a little bit about ECU's experience in teledentistry, mostly involving students, or how we can use technology that we apply to teledentistry for education and to further the access of rural communities to dental care. So Dr. Matthews already talked about this. So wait, this is it, can anyone see my screen? I think I'm having a little bit of a situation. Can you guys confirm my presentation is being shared right now?
There we go, we're back.
Okay, sorry about that.
Okay.
So Dr. Matthews already talked about the different modalities of teledentistry, so I will not expand on those. But the one point I kind of want to make is that usually asynchronous teledentistry, or to my opinion, the other two types of teledentistry by the American Dental Association, like remote patient monitoring and mobile health, they kind of overlap with asynchronous teledentistry quite a lot. And I'll show you some examples of how and why. So I'll talk a little bit about some of those different modalities in teledentistry. And the most common one will be the representative, for example, in my field, as I'm deeply involved in diagnostic sciences, I get this quite a lot. The clinician takes representative clinical pictures of a particular lesion, and that is sent directly to me, where in a secure email or sometimes over using the messenger system of our electronic patient record, where I can go on to review the radiographs or particular clinical pictures and then send a recommendation based on the information provided to the clinician. Another different modality we have, and this is something that probably it's been going on for a while, It's and particularly what the ADA, American Dental Association, talks about on stored and forward information. So particular, for example, a radiograph is stored in a secure server, like an electronic patient record or any other type of secure cloud or server. And then the consultant dentist can access that ancillary study or radiograph or clinical pictures and have a discussion or write an official recommendation based on that. And if you kind of think about it, this has probably been going for a while, or this has been going for a while, because now the whole, all our radiographs are digital. And whenever you want an official reading or interpretation of a radiograph by an oral radiologist, for example, you store that information and the radiologist accesses the radiograph and generates a report back to you. So you could argue that that's a type of, or already we're using a form of asynchronous teledentistry officially. Another type of asynchronous consultations is by using mobile devices, like, for example, mobile health, again, within or using the definitions of the American Dental Association. And for example, Epic, which is a pretty famous electronic patient record software system, has an app that provides the clinician the ability to take a picture of the patient lesion, for example, and that the picture will not be stored on the clinician's phone, but it goes directly to the patient's record. And then you can have a different consultant or specialist to look or to access the information and look at the picture and generate a report or have a phone conversation about it. Also, the technology gives us the opportunity to manipulate radiographs or pictures for better assessment of the area in question. For example, you can zoom in on the particular radiograph, you can change the contrast and the brightness of the lesion or that particular area of interest for better assessment. And this happens all the time. And usually whenever it happens to me, and I usually tell my friends to get at least a patient's verbal consent. But this has been going on probably for a while, since now we have the access to all this technology and mobile devices. I can probably take a quick picture without any identifiers or a picture of the radiograph and send it to a colleague for a quick consultation, probably while the patient's still in the chair. And this is one of those examples, and you could probably argue that I was doing remote patient monitoring. This is one of my friends, he's a surgeon, and he's pretty far away. I don't know anything about this patient. I don't know her name, etc. I just have a picture of a pretty nasty lesion on her tongue. And there's not a lot of messaging here just because we have a phone conversation about it. But then I was able to see the patient and how the treatment plan we agree on was actually working a week later, and how, as you can see on the second picture, that the ulcer or that lesion on her tongue is resolving. Another one of another application to asynchronous teledentistry is that once the clinician provide, for example, to me a picture, I can manipulate that picture to answer a particular question or to focus on something specific. For example, here, if the surgeon wants me to know what type of, as a pathologist, where to take a particular sample of a lesion for me to look at on the microscope, I can mark the picture and suggest particular areas and email back or send that back to the clinician of exactly the areas that I would like to see on the microscope. So I'll focus mostly on asynchronous teledentistry, but also on our institutional experience and how we are currently handling teledentistry. And as you guys know, we have 8 different satellite clinics or community service learning centers across the state, which give us the opportunity to, and in this community service learner centers, our dental students rotate there. which give us the opportunity to have them become familiar with teledentistry and technology available for them to consult faculty members here in Russell while they are away on their rotations. And once they graduate, they already have, they're already comfortable using this technology. So again, I kind of already talked about this, and this is usually what I request my dental students whenever they consult me. The accident number or the patient's medical record number, just so I can go into the patient's record and look at past medical history, possible medications the patient might be taking, etc. Clinical history and clinical impression, mostly also for an educational purpose, just because it's up to me now that the, for example, dental student or resident is consulting me, it's up to me to turn this into this opportunity or scenario into an educational thing. And then I can write back the email or the or during or on Axion Messenger system with a recommendation. And we also performed live consultations by using WebEx or Cisco Yabber, which is Cisco is usually more is a more of an internal software. So this is currently how my office looks like. As you can see, I have a flat screen with a Cisco camera, and I'll show you how all of this is worked. But this gives me the opportunity, this frees my computer so I can go into the patient's medical record and look at possible radiographs as the clinician is showing me a particular lesion or area they want me to give them my opinion on. And this is an example of what a live consultation goes on. This is the patient was in actually Spruce Pine, and I was here in Greenville. So again, because it's all ECU School of Dental Medicine, I can access the patient's medical record from my office. The patient can turn around, they can look at me directly, we can have a conversation, and I can talk to the clinician as well as I am looking intraorally, because the clinician, as you can see here in the picture, has an intraoral camera. And this is another thing I get pretty much all the time. And this is, I talked a little bit about this. This is one of our dental students, well, now colleague, class of 2020, that was consulting me. She will provide, I blocked it out, the patient's medical record and a little summary of the patient's story and what is the problem-based consultation. And I will reply to this with a recommendation. Me being a pathologist, as you can see, I can also apply teledentistry to my particular field. And I can, as you can see, this white box attached to my microscope is a camera. I can take pictures of the cells of the microscopy I have and send the representative pictures to a different colleague, a different pathologist, if I'm puzzled about a particular case, or we can actually meet over WebEx. So multiple applications with honestly not a lot of equipment. So now I can talk to you guys about our use of teledentistry during the COVID-19 pandemic. And so right now we have set up a full teledentistry service for our patients, and they can use technology to access a dentist or a specialist for our problem-based consultation. They can whether take pictures of themselves and email them after they were screened by front desk over the phone, and we can reply to that particular consultation upon request. And also we've been using WebEx for live consultations. We can set up virtual rooms with our patients. For example, I've been following up on a lot of my patients, and because I are my patients, I can, for example, send prescriptions to a particular or to a close pharmacy. In those patients that obviously do not qualify as an emergency, and they really during this pandemic, they don't need to be here for a face-to-face consultation. So it has multiple applications, and we were able to easily apply this during this pandemic. And another thing that is very important, and we usually emphasize this to our patients, especially during our consent form, is that we're using a HIPAA compliant software, which is WebEx. And it's very easy to use. And this is something, those particular links are in the patient's brochure, just so they know they can refer to, for example, the Cisco white paper on HIPAA compliance and what happens with their information. So I'm happy to entertain or answer any questions you may have.
So Dr. Flores, there is a question that came in, and it states, you have a very impressive closed pathology consulting system between Ross Hall, which is your ECU campus, and your service learning centers throughout the state. Are there any thoughts about making this service available to state FQHCs or federally qualified health centers and health departments?
Yes, we currently, a few weeks ago, we got a grant to expand and to get better equipment or renew our equipment in teledentistry. And that's something, I guess this pandemic was a good opportunity for us to reevaluate and see how we can expand our dental, not necessarily just in oral pathology, but to different specialties. So yeah, we're in plans. We have that in plans to expand for sure.
That's great. Thank you again for agreeing to speak and sharing all the great work that ECU is doing. I had the pleasure of going to one of the service learning centers and seeing it in action. And it's really quite impressive how you're able to synchronously connect back at Ross Hall with some of the specialists, such as yourself, to review pathology, to walk folks through where to biopsy. So there's a story that I've heard where there was a clinician out in a service learning center, and not sure, Dr. Flores, if it was you or someone else, but someone on faculty in real time was able to walk that clinician through in the service learning center where to take the biopsy tissue, which is extremely helpful. The other thing that you mentioned, I think it's really important for all of us to understand, is that teledentistry, even asynchronously, has been happening for many, 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 many years. Your colleague, Dr. Rob Temple, has shared stories about his time in service out in remote islands in Fiji, I believe he said, where they were actually transmitting images asynchronously through satellites back in the 80s. And so, the question I often ask folks is, how many dentists have ever sent an image just like you received on your iPhone and asked a friend for a informal consult? What do you think of this? And that happens and has been happening for many years. It's just never been formalized through definition or practice acts or with reimbursement. So I think the technology is not necessarily the issue. The broadband is still an issue, very much so. But in terms of next steps, and we're going to talk about that a little bit later, I think we're really at that tipping point where we can move forward. So thank you for speaking and sharing your expertise.
Yeah, thank you for having me.
Absolutely. So we're going to move on to Dr. Bill Donegan over at Contegra Health.
Let's see if we get this working, Zach.
You're up and live, Bill, so we're
All
good.
right. Well, I want to say thank you to Dr. Brian and the Oral Health Collaborative for hosting Oral Health Day, and especially for all of you being here. And I kind of feel like now that we've heard from Dr. Matthews and Dr. Flores about synchronous teledentistry and asynchronous or store and forward teledentistry, let me tell you a little bit about Contegra Health. Contegra Health used to be called Gaston Family Health Services. I came here in 2007. In about 2004, I left private practice after 21 years to move towards the public health side of things. So my big question right now is, well, let's see if it works, Zach. It's not, I can't tell if it's, no, it's not. For some reason, it's not operating the way I want it to. Let's see if we can get it here.
You keep trying, Bill, and in the meantime, oh, there it
There it
goes.
goes. How does it really work? Teledentistry, that is. I'm not 100% sure that everybody understands it. I've been using technology like this from back in my private practice. I used intraoral cameras back in the 90s when all we could do was print them on a Kodak printer. So life has changed a little bit. And the biggest reason is this. Basically, we were told by the CDC back on April 27th that we were to use teledentistry or telecine or teleconferencing or whatever you want to call it. We all did it before, like Dr. Brian and Dr. Flores talked about. You know, we all did it. We just didn't understand it all, or that it was something we could do down the road. So for us, how do we, Contegra, do teledentistry? And I really want to talk about a few things because I'm going to talk about 3 different ways that we use teledentistry and 2 ways that we use our technology. Now, as I said a little bit about Contegra, Contegra is the largest FQHC in the state of North Carolina. Last year, we saw almost 36,000 dental visits. And we were on par to probably reach 42,000 this year prior to the COVID epidemic. So in this day of COVID, what do we do? So for us, it all starts with a phone call. We have to have that phone call because we dropped from about 3,500 visits a month to 500 since all we could do was see emergency care. So basically there's 2 types of patients. They're either patients of record or patients that are not of record. They may be someone else's dentist, maybe their dentist, and that patient still needs to be treated in an emergency basis. So we get like Dr. Flores said, we make sure we get their email. We get an initial verbal consent for teledentistry. If they don't have access, then they have to be seen. But that's only if the telephone triage with our patient service representative indicates that. If they're not a patient of record, we then guide them to our paperwork on our website and move forward from there. As a rule, the patient isn't given an appointment during that emergency only, unless we have some paperwork for them. So paperwork. My favorite comment was from Paul Glassman. Paul is the father of teledentistry in the United States. He said, we love our patients and we love seeing them, but we want to see them in this epidemic time for as little time as possible in our offices. And so what we've done is we've totally tried to make it the responsibility of the patient to fill out that paperwork. They can download or answer all the questions right there online. Patient information, patient demographics, health history, everything is done in English and Spanish online. They can apply for the sliding fee at our health center and how they respond or how to take the photographs that we need. So we go through, typically like everyone else, consent. We also have screening questions, the same screening questions that have been around with some additions, you know, the blue toes, the loss of taste, etc., that we've added to this. And then the patient is asked to take some photographs with their iPhone or Android. Those photographs are asked to be emailed to us. We ask only to have 3 of them done in an email, mainly because if you get it too big, the patient's email doesn't go through. So they will email us back. They get a copy of this of how to take those photographs. The comment that I make about it is, no, they're not the greatest. And my providers have said, oh my gosh, he's got to put clothes on, or other things like that. The fact of the matter is that these are better than what you would think. And that's not a bad picture. That's just an iPhone with a flash. We get some connectivity to the patient. The big key is this bilateral connection with our patients. So once they've returned the photos to us and we've uploaded them into our software and all of our documents are returned and loaded into the software, we notate within our clinical notes that they've all been there and the consent is there. Then the patient services representative will call the patient and establish an appointment time with the patient and the provider. Once they have connected, the provider will then follow our protocols, just the same as if the patient was in the office. The notes are the same, everything is the same, and then the patient can be referred to another provider if need be, to the clinic for care if need be, or, as is sometimes the case with children, to the pharmacy to get some Anbesol and to wiggle that tooth out a little better. That happens a lot with our pediatric population. So another way that we use technology and teledentistry is what I consider to be the biggest buzzword out there right now, integration. We want to connect our medical providers to our dental providers. And thanks to Mouthwatch, we've added cameras in all of our medical staff, thanks to our medical director, Dr. Shirley Aklu. Very progressive thinker. She saw the pictures. She said, every one of my providers needs a camera like this to be able to direct care. And that's the biggest thing. We want to keep our patients, Dr. Matthews talked about it, we want to keep our patients out of the emergency room. In Gaston County, 13% of the emergency room visits are for oral pain. That's vital for us to keep patients out. We have an arrangement with the hospital where they refer to us, but there's still people who show up at the hospital. Many instances, the patient shows up for an examination with the physician, and the physician, sorry to say, doesn't even look in the mouth. In many instances, when they do, they will go, oh my gosh, what's that growth? And it might be a torus. Nothing that we really are concerned with at all, but they get concerned about it. And in the old days, and I'm old, we literally would get referrals from medical providers for a neoplasm or a growth in the floor of a patient's mouth, and it was a torus. So that happened. Now, they're supposed to look in the mouth. I think more and more of them do. And sometimes it leads to areas of concern, especially in our diabetic population, as we've learned that diabetes and oral health are very much linked. So there's also the instance where patients present and tell the MD that he or she is having pain. I can't tell you the number of phone calls I get from medical providers who say, I've got this patient here, they're swollen. Well, why did they go to the medical provider? Because they couldn't get into a dentist. The dentist wanted cash up front. They knew the health center would see them. All of those reasons fit into what we do. And now they get an opportunity as a medical provider to take photographs in the mouth. We're still learning how to use it. We're adding another 50 cameras to our organization. The cameras are not overly expensive. I think they're $299. There's software available that actually can create the teledentistry link for everybody. We're experimenting and trying to figure out how we're going to use all of that, and training our medical providers right now to take the intraoral pictures. Now the medical doctor and the dentist can converse about the condition, and in some instances schedule time for the patient with the dentist. So these are some pictures I took with our first intraoral camera, mouthwatch camera, in the medical practice. And I was there with the medical provider, and she said, and our medical director, Dr. Oclue, said, we need one of these for every one of our medical providers because they can take a picture like that just as easy as you could. That's very true. So one of the things that I'm so proud of with Contegra is our school-based program. But how do we use teledentistry in our schools? Beautiful picture of our mobile dental unit. We now have 2 of them. One that services Gaston County, Lincoln County, and Southern Catawba County, and one that services the rest of Catawba County and Iredell County. We also have mobile vans that go to Davidson and Davie County. So our program is also known as the Dental Access Program. It was begun in 2006, right as I was getting here, with about 250 kids. This year, we saw over 4,900 children, and we had to stop in March. We were looking at seeing around 6,000 to 7,000 children. We do provide only preventive services, exams, cleanings, x-rays. That mobile dental unit has a digital panoramic, and it also has a Nomad in case we need other x-rays. So we only provide preventive services, including sealants and fluoride. The big uniqueness to our program is what I call our navigators. When I installed our first navigator in about 2010, we had one, and that was because our program was growing so fast that our Melissa Bowman, who is our director of this program and a registered hygienist who had been doing hygiene about 20 years, just couldn't spend time enough calling all the parents. Our navigators contact the parents within 48 hours of that child being seen. We then can direct the care for that child and get them in to where they need to be. So we're hoping, Dr. Matthews intimated that there are going to be some changes, and I hope there are. The future is now, Sean. We are training our hygienists to be public health hygienists so that they can participate in the 16W program. Our staff model right now is a dentist with 3 dental assistants. They're all DA2s. They work on the bus September 10th to May 20th. But our new staff model, beginning this September, will put a dental hygienist, 2 dental assistant 2s, and 1 dental assistant 1, who will also act as a PSR. And that DA1 will do the x-rays, the photographs, while the DA2s and the hygienist will do the cleanings, fluoride, varnish, sealants. And what our hope is in all of this is to use store and forward technology that Dr. Flores talked about to send those photographs, send those x-rays to a dentist who on Wednesday may be in the clinic treating patients, but on Thursday morning is viewing all of the exams that happened the day before. That dentist then can review the notes, the photographs, the x-rays, create a tentative treatment plan, and then the navigator can schedule with the same dentist who performed the teledentistry visit at a physical location near that child and work to get that child in, because the end result, treatment is completed. We're looking at another model that's really helping us out. We call it Smile Cares. In this post-COVID environment, everyone's seen the surveys out there that 50 to 60% of the population are unsure if we should be out and moving about, and they're not sure what's going on. And we also have patients who are unwilling to come in for that reason. We also have children who, less than age 5 or so, have behavioral guidance issues, and we can't get much done on them when we do treat them in the clinic. But more importantly, what if, like all the media is purporting, we're going to enter into a second pandemic shutdown? If we have a child who was here in September and was due in March and didn't get in March, and they're scared to come back here in May, June, July, and we head into another pandemic, it can be a year or more before that child gets back. And any dentist will tell you, especially with children, Darlene mentioned soft drinks and other things, that in that year, you can go from a child that looks absolutely healthy to a child who has 8 to 10 cavities and needs hospitalization to be taken care of. So our goal with this program is to take those low to moderate caries risk patients, behavioral guidance patients, or just children who are with unwilling parents that don't want to come in, to provide education, oral hygiene instruction, fluoride placement. Our goal is to offer a digital video format where they can view a video on oral hygiene instruction, brushing and flossing, and fluoride varnish placement. Our goal is to have the provider talk with the parent while the child is there, so that we can actually create a teledentistry visit for that child and give them all of the education they need. It's not perfect. It's not great for kids who have incipient lesions 6 or 9 months ago that may have already progressed, but it is a way to provide preventive services to our kids. So how can we use teledentistry, or in my mind, technology, to educate our patients? We're actually putting mouthwatch cameras in all of our hygiene operatories. We're putting a video monitor on the light poles so that the patient can view it. By putting those cameras in our hygiene rooms with the hygienist, we now create an environment where we can magnify, you saw the pictures, 30 times bigger, maybe 100 times bigger than what we can see with our magnification loops of 2.5 to 3.5 times. They can also, as the hygienist, and what mine used to do years ago was take that video, go around the mouth. They can help educate the patient about hygiene, broken restorations, the need to restore certain teeth, and also the anticipatory guidance for kids that we need to be talking with the parent about. So the one thing I always hear is, what do you do with those big, nice mobile dental units when you aren't in the schools? I will tell you that this environment of mobile testing is phenomenal. We decided after about 2 weeks to use our mobile dental units out on site to do mobile COVID testing. That mobile COVID testing, prior to the buses being used, and I hate to use the word buses, was about 120 tests. Since the time we started using the mobile dental units, which act as a giant billboard to attract attention and get people to come in, we've now done 1,100 tests, COVID tests. The buses aren't perfect. We don't bring the patient on the bus. The bus is really for our staff, but it also provides a refrigerator, a cool place for them when there's no business, and a place for them to store supplies and take those supplies in one motion out to the site on a daily basis. So I always talk about this, and it's an interesting thing. There's a quote from a friend of mine, Zig Ziglar, who I met many years ago. The 3 C's of life: choices, chances, and changes. You must make a choice to take a chance, or your life will never change. And I tell you right now, we have the opportunity. We need to think outside the box. We have the opportunity to expand teledentistry through legislation. And I ask you, what can help us better to serve our patients now and in the future? Thank you.
Thank you so much, Bill. I think the presentation was great. You know, you highlighted and kind of tied the two previous presenters together, and you really focused on, you know, teledentistry's use in other modalities such as patient education and out in the community and schools. So I love what you're doing. I love that you're starting to integrate those intraoral cameras into the medical practice as well. It's very beneficial. We did get a couple questions that came through. I'm going to save those to the Q&A. We're running a little bit behind on time. But if you have questions, you know, make sure that you ask them during the Q&A at the end. So now we're going to move on to Dr. Alec Parker with the North Carolina Dental Society.
Trying to stop sharing.
All right, Alec, I think you're up.
Okay, are you with me? Am I with you? Okay. All right. Thank you so much, Zach, for the opportunity to speak with this group to share some information there about provider community buy-in. I also want to thank all those who provided me with some information that is within this basic outline that I'm going to share with you today. So although teledentistry is considered to be a relatively new method of providing dental care, we know that telehealth has been an evolving trend for a number of years in other healthcare disciplines. Mental health professionals, particularly psychologists and psychiatrists, were early adopters in the telehealth world. All they needed was a phone and a place where a conversation could be held in private. Recognizing that trend, several years ago, the Federal Health Resources and Services Administration created a definition of telehealth. And as telehealth technology has progressed, an increasing number of healthcare providers have been utilizing that modality to deliver care to patients whose needs could be addressed without the provider and the patient being co-located in the same room. So when I look back on my years of practice, I remember back in the 80s where I thought it was a big deal that we had intraoral cameras for our hygienist to go around and do what we referred to then as a tour of the mouth. And in those cases, if we were suspicious of some kind of pathology, or we felt like there was an opportunity to educate patients regarding home care, we would take some images, and basically that's as far as we went. But things have really changed now. There are 5 sequential steps involved in introducing teledentistry to the dental community. Interestingly enough, these steps are quite similar to the 5 steps that are employed when consumers are making any buying decision, whether it be the purchase of a new car, perhaps a new home, a home appliance, or even teledentistry. The steps in this process, which is called the buying decision, are number 1, awareness, number 2, curiosity, 3, the evaluation of alternatives, 4, the purchase decision, and then the final one is the post-purchase evaluation. So I'm just going to briefly walk through those steps to see how they might apply to enhancing the provider community buy-in for teledentistry. So the first step is awareness, which is defined in the sales world as the recognition of a problem or an opportunity. So awareness can come from several sources. It can come from just a offhand conversation with dental colleagues at a local dental society meeting, at a continuing education course, or even a social event where shop talk just kind of enters the conversation between dental colleagues. Dental supply company sales representatives are also very good at sharing information about new technology that is coming forward within the dental world, particularly if that dental supply company happens to sell that modality. Of course, there are also dental meetings where exhibitors are present and they can describe and demonstrate teledentistry equipment, and that kind of hands-on demonstration is a lot of times the catalyst that starts the wheels turning in a dentist's head about how he or she might be able to use that technology in their practice. So the next step is curiosity, and that's where basically the potential buyer takes the next step. They want to dig a little deeper instead of just these casual, I guess what you could say, happenstance opportunities. They actively seek information, and they'll go to the internet. If they have a dental school, they'll certainly reach out there. There are peer-reviewed journals and newsletters that talk about new products in the dental world. There's certainly some commercial resources out there, but I found just in some of the conversations I've had that one of the most effective things for the person who is considering this is a visit to a dental office that has implemented teledentistry.
Alec, can you hear me?
Yeah.
Sorry to interrupt you. We just got word though that Representative Lewis has to jump off at 11.
Okay.
Okay for you to wrap back up after him?
Sure. Absolutely.
All right. So Representative Lewis, I'm going to give you the floor. Thanks for letting us know that you had to jump off, and hopefully we were able to accommodate you.
Good morning, and let me be clear, it was never my intent to interrupt Dr. Parker. I was actually enjoying his presentation and was enjoying the presentation prior to his. Teledentistry is a new frontier, and certainly something that I look forward to continuing to learn about. I'll be brief and help you get back on track here. I do want to thank the North Carolina Oral Health Collaborative for inviting me to take part in this discussion. We at the General Assembly understand the challenges that face our constituents and our healthcare providers during this very strange time. I'm a huge proponent and believer in oral health. I have seen firsthand the stigma that comes with people that have not had access to proper oral health. The bad teeth is often a precursor to a less than full life. It's not really fair that it's like that, but it is like that. I've seen it in my own family and certainly in my community. I was excited whenever the Oral Health Collaborative folks come by to visit. I look forward to getting to learn more about the issues that are important to us all. I certainly look forward to more conversations on the teledentistry front, and please know that the dentists are an important part of our community as healthcare providers, but also for the jobs that you provide for the good corporate citizenship that you all provide. I sincerely appreciate that as well. I know that we have a long way to go. There's a lot of new things to discuss. The presenter right before Dr. Parker talking about the technology that would be required to actually do the teledentistry. That was absolutely just fascinating to learn. And those are the kinds of things that, with the good advocates that you have, including, of course, Dr. Parker, we at the General Assembly look forward to getting to learn more about these issues and look forward to getting to work with you. And I'm so sorry that I have to run. They've got me booked to 2 or 3 different things today. Or honestly, I'd probably watch the rest of this presentation because I really have enjoyed it.
Well, thank you so much, Representative. We're glad that you could join us and agreed to do so. And we very much enjoyed our conversations with you as well down at the General Assembly, and more to come. And so thank you again.
Thank you much.
All right, Alec, I am so sorry to do that, but I just wanted to make sure we gave him a platform before he has to jump. So now back to you.
I'm thinking I'm going to have to start all over. Not really.
Okay.
So I think I was at step 2, which is defined as curiosity. And I would just say at this point where the potential buyer is seeking additional information from various sources, I think this is a great time to involve your staff, involve your complete staff, not just the clinical staff, but your entire staff in this process. Because if you elect to go down this road, your entire staff needs to be educated about teledentistry, about what it can do, what it can't do, and how it's basically going to be implemented or I guess integrated within your office procedures. So it's very important that staff, in my opinion, it's very important that staff be involved in this. The third step is where you begin to, I guess, cull the herd, so to speak. You've made kind of a overview look, a 30,000 foot look at the opportunities out there, the different companies and everything, but you're learning more about teledentistry equipment and you're trying to determine how is it going to be a good fit for you, which of the models from A to Z are really the best fit for your practice. I don't think there's a one size fits all. Of course, when you talk to the various vendors, they're going to talk about the best one or the most popular one. And I would just say, it's been my experience over the years, whenever I was purchasing something when I was in practice, sometimes I found that what was the most popular or the one that was the highest rated really just wasn't the best fit for us. So site visits at other offices, talking to the people in your practice who are going to be using it, chair side, certainly your dental assistants, your dental hygienist. Like I said, the whole team needs to know what's going on there, and they need to know how to use it. So you need to know up front that that takes time. It's getting easier and easier to implement and to use, but still you want people who are comfortable using it in your practice. So the fourth step is really the buying decision. When you have taken the time to do all your homework, you've talked with your staff, you've talked with colleagues, you've tried to check every box, and you have gone through and you have looked at what are the most important attributes and capabilities that can be delivered through teledentistry. And you want to make sure that your choice fulfills those dominant needs of everyone, or you'll find someone in your practice who is not maybe as comfortable using it because they don't maybe address some of the things that were important to him or her. So I would say, you know, you want buy-in, you want people to be excited, you want people to have a good experience. And then finally is the post-purchase evaluation. And that's really when kind of the rubber meets the road. The customer has had a chance to, you know, implement, and still there's usually a period where there will be access to support for free, and then ongoing support, just like with any other technology within your office. You want to make sure that during that post-purchase evaluation, which is really based upon the level of satisfaction or in some cases dissatisfaction that you've experienced, you know, you want to try to work through all those things and make sure that everybody on your staff is comfortable and satisfied and can discuss enthusiastically, just like Dr. Donegan did here a few minutes ago, about all the technology that's available now within his workspace. You want those members of your team to go out and be evangelical in a way to promote your office as well, and how it aids in better dentistry, and it involves the patient and their involvement and engagement during the decision-making and treatment planning development process goes a long way to ensure their post-treatment satisfaction. So with that, I'm going to stop and say again, thank you for the opportunity. I've enjoyed listening to all the other presenters, and I'm going to hang around and listen to Mr. White at least.
All right, sounds good. Bobby, we're running a little bit behind on time. Take as much time though as you need. And kind of from you, I'm hoping we can hear, you know, as we move forward with the legislative pieces, you know, what that process looks like from the board's perspective.
Thank you, Dr. Bryan, and appreciate the opportunity to be here, and appreciate the work of the collaborative and being able to work together as we have over the past several months and years. I know we're behind time, just a 30,000 foot view. In the Old Testament book of Psalms, there is a line a verse that says, "It is God who made us and not we ourselves." And I sometimes paraphrase that to say, with terms of the dental board, it is the General Assembly who made us and not we ourselves. The board is a creature of the General Assembly, and we have oversight by the General Assembly and some other agencies of the government. We have, of course, most of you may be familiar with the Dental Practice Act, the laws and rules that govern the practice of dentistry in North Carolina. There's not a single law in there that was passed by the dental board. All of the laws are passed by the General Assembly, and that's why what you are doing as the collaborative is so important. This kind of grassroots organization where you bring an issue before Representative Autry, Representative Lewis, all other interested representatives and senators to affect change through the legislative process. We often get a question, well, why didn't the board just change that? The board has no authority to change any statutes. It has to be done through the legislative process. So I'd like to just say that as one of the foremost main points of today. Once the legislature passes a statute, it does give the board authority to draft rules. For example, the legislature may pass a statute that says the board is allowed to collect information on applicants for dental license. Well, once that statute is passed, we can then pass rules. Well, here's what a board application looks like. Here's the information that we're going to collect. But even then, the board doesn't ultimately pass that rule. It has to, we can suggest language, but it has to go before the Rules Review Commission of the North Carolina General Assembly to be approved. So both statute and rule are ultimately approved through a legislative process that is outside of the board's authority. However, it doesn't mean that we can't have comment, and we're quite often asked to comment. And one of the things, the second point I would leave with you today is that I would hope that anyone listening or anyone involved in this process would not see the board as a barrier. We do our best to advise, to guide, to assist licensees, members of the public in understanding the current law as it exists and how changes to that law might impact other areas of rule and law that would impact the process or the practice of dentistry and dental hygiene in North Carolina. We really are doing our best not to be reactive, as may have been seen in the past, but to be proactive, to help folks with any process with dental change. And here in teledentistry, when the Dental Practice Act was passed in 1935, I don't think teledentistry was on anyone's mind. And so the law is going to have to catch up with progress. And we'll be glad to help any way that we can with that, generally as a consulting role in the background, because we don't have authority to change things. I'd be glad to answer any questions if I can.
Thank you so much, Bobby. I think it's helpful, to folks to at least get a broad overview of what that process looks like. And one thing we're considering doing in the future when partner with other agencies is just doing a pretty in-depth review of what the legislative process or rulemaking process entails. And how to best engage, all the voices across North Carolina in that process. So thank you, for being an advocate, for change and innovative solutions such as teledentistry. And thanks again for speaking today.
You're welcome.
So I'm going to shift gears here for a second and go ahead and share my screen again with you to wrap up the slides here. I hope everyone can see my screen here. I'm not going to go through much of this slide, but just to reiterate the fact you've heard from so many different speakers that are using teledentistry in many different ways. And so it's not a one size fits all approach, but there are so many opportunities for the use of teledentistry and really connecting vulnerable populations to access to oral health care. So specifically as it pertains to the Oral Health Collaborative, we are hosting this event for a purpose, and that is to discuss moving forward with a legislative bill draft as it relates to introducing teledentistry into the Dental Practice Act. So I'm going to go through a little bit later on just kind of the steps that have been taken to get to this point, but you'll see the draft language, a sample to the right here. And so there are a couple areas, and not to get too in depth with the policy piece, but there are areas in which we need to look to add to the existing Dental Practice Act and amend. And then of course, what you heard other folks mentioning earlier today, they have to be in parallel with payment reform. So we need to make sure there's continuation of payment for the codes that Dr. Sean Matthews had mentioned, as well as in tandem with the legislative piece. So in laying the groundwork, we did several things over the last year and a half, and really even before that. First was we started the community education piece at a telehealth summit held in Asheville, North Carolina on March 1st in 2019. And then we took a group of stakeholders out to California. The Dental Society was represented, as well as the board and many other stakeholders, to view the virtual dental home model with Dr. Paul Glassman, who I think Bill Donegan had mentioned, and that was last summer. And then from that, we took a similar group, including representation from the Dental Society and the Board of Dental Examiners and other stakeholders, to the Medical University of South Carolina, or MUSC, to view their HRSA, Designated Center of Excellence in Telehealth. To put in perspective of what we saw was pretty mind-boggling of what they're doing. And it's well beyond, I think, the first steps for North Carolina, but it really set the stage of what's possible in moving forward with teledentistry legislation and payment reform. And then, as Dr. Matthews had mentioned, there was a symposium held jointly between UNC and ECU on March 6th of this year, in which I spoke. And then here we are today, obviously, on June 3rd for Oral Health Day. So just a sampling of all the stakeholders that were present for the California trip, you'll see in the photo on the right-hand side here. And similarly for the trip to South Carolina. So as you can see, there are all these monitors in this room. It was quite spaceship-like, pretty fitting as we just landed back on the space station, which was pretty exciting this week. So where we are now, we have drafted the legislation, as I showed you a photo of that previously. And then that has been vetted through an array of diverse stakeholders and ultimately went to the Teledentistry Task Force, which is an extension of the North Carolina Dental Society Council on Prevention and Oral Health, in which stakeholders were able to provide feedback that was incorporated into the draft we have currently. And then now we are moving forward with opportunities for introduction of that language. So just in terms of Oral Health Day, what's next for those that were not on the pre-event webinar, Oral Health Day obviously was a little different this year, but we ended up splitting it into two parts. So this is part one. And part two is actually a community impact initiative where we'll be partnering with federally qualified health centers in 3 regions of the state to host community members, legislators, providers, et cetera, and all stakeholders to convene in a town hall fashion at those health centers to see a demonstration of teledentistry, be able to see it live, ask questions, and then meet with your representatives at that time. So the 3 sections were just split between West, East, and Central. And I'm going to share these slides with all the registrants for Oral Health Day after the event so you can take a look at where you would fit in terms of region. So we'll get to the Q&A in 1 second, but I just wanted to make sure that this is a piece of why our advocacy event takes place, and that's because of you. And so definitely I would encourage you to attend part 2 to kind of further your understanding of teledentistry and be able to ask direct questions to the providers and the community and the patients that are being treated through this modality, as well as your representatives. And then definitely feel free, to reach out to your legislators, call, email them, talk about why teledentistry is important for this state, talk about, the stories that we've heard as we've gone around and listened to community about the access barriers that exist. You can do that many different ways. You can contact us and we can provide that information to you. There's also a website that's linked on our site that will allow you to navigate and identify who your representative is with their contact information. So I love this quote, and you've probably seen it before from me, but it really is the whole reason the collaborative exists. Individually, we're a drop and we can make some movement, but together we're really an ocean and can make more movement and more change that's positive for the state. So thank you. Over the last year and a half, there's been so much engagement, so much support from the community for the work that we're doing. And I just encourage you to keep that momentum going. We're here really to serve you. Our contact information is listed here. That's our direct office number. On our site at oralhealthnc.org, you will find my cell number as well. So if you want to reach out directly, feel free to text or call me or email me or any of the staff that are listed. So with that, I'm going to conclude the end of this presentation and then open it up for folks that may have questions that were left unanswered. The other opportunity we're going to have is we're going to create a portal in which participants in the community at large can submit questions following this event that will answer in the event that we don't get to them today. So feel free to unmute yourself if you have a direct question that you want to ask. We're right on time. I'm surprised that we didn't have any more technological glitches, actually. So thank you again for everyone that has attended today. And we look forward to future work with you, teledentistry forward. But want to open it up if there are any questions. We're going to stay on to about 11:30. If you need to jump off, I completely understand. But if you have specific questions, stay on and ask those, please.
Hello, Zach, may I make a comment?
Yeah, absolutely.
It's Sean. First of all, once again, thanks to you and the Oral Health Collaborative for a tremendous job, really well done. It's been a pleasure to be a part of it. I just wanted to make a comment based on Bill, Dr. Donegan, your presentation was as elegant and eloquent as always. And just one of the things that we often forget sometimes is that this whole issue of access to good oral health care for the rural and underserved communities, and how and why they attend emergency departments up and down the length and breadth of the land, is that the dental problems, dental pain, dental related problems actually amongst the top 10 reasons for patients attending ED departments. So there's a lot of it that clearly goes on out there. And I think something that's often we forget. But the other reason I mention that is because those patients, when they do attend ED departments, they are being seen by physicians, as Dr. Donegan mentioned, who don't have a clue about oral health and teeth, dental related issues essentially. So especially for someone out in the rural community, they will know this is a tooth, but that's about the limit of it. So really their initial management tends to focus almost entirely around throwing antibiotics and painkillers, often opioids, at the patient and telling the patient to go off, head off, and of course contact or go and see a dentist the following day or at the end of the weekend to get their problem addressed. Often these patients will not do that. They will take the opioids, they will take the antibiotics, they'll get a short-term fix and improvement in their problem. But of course, the problem returns with a vengeance later on. And what was a controllable, easily manageable problem then becomes a much bigger life-threatening issue, like the last slide that I showed in my presentation. So the connection that this has with the opioid crisis that we have here in our state must also not be understated, must not be forgotten, because it is real. So I think we mustn't forget that. So when we try and keep these patients out of the ED departments in the way that everyone here has described today, it's for a good reason. It's so they can be treated by the people who can treat them better and most appropriately. So they're not entering into this vicious circle, this vicious cycle of just having antibiotics and opioid analgesics hurled at a problem which is not really a fix. It just alleviates the pain, doesn't address the problem. So just to also just keep one's minds focused on that as well. Thank you.
Sean, let me add something that
yes.
One of the exciting parts for us is that we have partnered with our local hospital to have patients directed directly to our dental clinic. Excellent. So that we get about 15 patient appointments a week from the emergency department. But what we're talking about right now is actually putting a mouthwatch camera in the emergency room.
Absolutely. That for me is the gold standard, Bill. I think that's great. Absolutely right. So that there's someone who can, and that's using teledentistry at its best. Yes. Getting someone to assess the patient. It's not rocket science training someone, even a doctor. I'm a doctor. How to wave a magic wand and to trail a mouthwatch camera in someone's mouth. As long as you can see the image, you can give a very good view of what should be done next. So I commend you wholeheartedly. Great result.
Absolutely. I wanted to make sure we get to one question that came in the chat. Someone had written in, it says, as a pre-dental student, an African-American woman, how can we bring these services directly to their communities? For example, some parents do not have transportation and some do not have access for their own care, so their children's care ends up following this cycle. Bringing programs like DAP, as Dr. Donegan had mentioned, directly into the community will be ideal to meet them where they are. We have to reach children even when they are not aware of the importance of oral health. I'm not sure who this came from because it just shows up as iPhone, but thank you so much for asking this question. And I think you so eloquently actually stated this. That is absolutely true. As we think about what teledentistry's role could be, from the collaborative perspective specifically, we're thinking about community-based settings. We're thinking of asynchronous teledentistry. Not that the others are not vitally important, as we have seen from the presenters today, but we have to start thinking about how are we going to bring care to people where they are. That's the goal. So we need to bring access to care where people are. And that includes in nursing facilities, in local health departments, in schools. So we need to bring the care to them to eliminate those potential risk of barriers such as transportation or time off from work, which is not an option for a lot of people. They're not able to take time off from work. So I thank you for whoever wrote that question in, but I completely agree with you, and that's the direction that we're heading with this legislation, is that it will open the doors to provide more community-based care.
Zach, let me just expound a little bit. One of the things that we've always tried to do is reach out to those type of environments, and what we do now this summer, we have 4 weeks scheduled at what's called the Dream Center Academy, or Boys and Girls Clubs, summer feeding programs, other things like that, where we can reach out to the community. And that's the important facet of everything going on.
Yeah, absolutely. We need to start thinking of dentistry as not just the four walls of a physical dental practice,
Exactly.
but engage other provider types as well, and making sure that we're meeting the needs of our communities. Happy to entertain any other questions that you guys may have as well.
Hi, I had a question. My name is Rachel Radford, and I'm an advocate in Wayne County. I help special needs families. One of the issues in my county is that my county commissioners will not fund any kind of dental care for the community. And so I wanted to know an opinion from everyone here, if you ever think that will be just state funding and it won't have to go through the county, because oral health is a significant issue in my county. And I'd really like to help Wayne County. And I'm not sure really the direction to go to do that, because it's not just special needs families affected, it's everybody. So I just was curious about the input, because my county commissioners, they did stop funding. So our health department does not have any oral health care whatsoever. So I'm just open to hear anybody's opinion or advice. Thank you.
Absolutely. A huge issue, Rachel. Thank you for bringing that up. I think, we have to think as broad as possible. So influencing local government sometimes is very easy to do and impactful, and sometimes we have to take it a little step further. And so I would, my recommendation is to make sure that you remain connected with other advocates that share the same view, which I can't imagine anyone not. Why would we not want oral health care access for all? But stay connected, build your own coalition, use your voice, at Raleigh, at the General Assembly. Definitely meet with those representatives and share those concerns. Anyone else? I'm surprised you guys, you held in there with us. We still have 77 people on past the end time, so that's exciting. Anything that people want to further expand on or have questions? Like I said, we're going to have a portal for submitting questions after the event, and we will be sharing the slides today with everyone that had registered. Well, if that is it, please definitely look out for communications and information from us about part 2. I think that's going to be a very impactful piece of this Oral Health Day, is really seeing it directly in community and how it works in real time. So we will be sending out communications to let you know when that opens. So the dates are still being vetted with the 3 health centers that I mentioned earlier. One thing that I would also recommend, if you're not already, go to oralhealthnc.org and make sure that you're signed up to receive our communications. So we have a wonderful, fantastic communication staff at the foundation that will make sure that all the communications on what we're doing are sent out to you guys. All right, so I hope that you have a wonderful rest of your day, and thanks again for joining us.
Thanks, Zach.
Take care.